because of the population I serve, most people get very metabolically flexible, getting their insulin down, getting their inflammation down, getting their hydration up, getting their organs of elimination functioning well. I think they probably accidentally were treating this without even knowing it.
Hello everyone, this is Felix, your favorite friendly neighborhood kidney hacker. And today I'm coming to you live from the Health Optimization Summit in London, which I attended a couple of days ago. And over there, I met someone pretty amazing, and it was Dr. Nasha Winters. She is one of the leading voices regarding metabolic therapy for cancer. She beat her own stage 4 ovarian cancer, diagnosed at 19 years old. Pretty amazing. And she's since then dedicated her life to becoming a doctor and revolutionizing the approach to cancer. She's the author of the book with a very similar title, The Metabolic Approach to Cancer. And when I met her, I thought it would be an amazing idea to pick her brain about metabolic therapies and to sort of pivot the conversation into the direction of polycystic kidney disease. Of course, not without letting her know first that that was going to be the topic of our conversation. So join us for this first of 2 interviews coming to you from the HOS in London 2024. Bear with me because the audio quality is not the same as you're used to with these studio recordings, as we were on the road and doing our best to sort of get in a place where there is acceptable audio quality. Enjoy this interview with Dr. Nasha Winters. Hello everyone, this is Felix Mueller, your friendly neighborhood kidney hacker, and today I'm at the HOS with Nasha Winters.
Hi guys.
So you just finished talking about cancer. It was an amazing talk.
Dun.
Very different approach than we hear usually.
Thank you.
This podcast is about polycystic kidney disease, and it has a lot of similarities to cancer. So even though you don't have PKD, knowing that there are a lot of similarities in the pathological cell multiplication that we don't know, that we don't want to have.
Yep.
What would be like your first association? What would you tell somebody that's diagnosed with this? And how would you approach it if it were you, if you didn't know much about it?
I love it. Well, first of all, I really appreciate that you see these cross-pollinations into various specialties and various organ systems and whatnot. And what I would do no differently than I do with a patient with cancer is I'd look at the terrain. I'd look at all the things, because our kidney is it's our filter. It is our major organ of elimination, along with a few other important ones like your liver and your skin and your lymphatics. But it is also one that takes a beating. It's very sensitive to a lot of changes in blood pressure, to changes in toxic burden, to changes in just the perfusion aspect of blood pressure, just oxygenation. But it also has a lot of genetic, like epigenetic implications, metabolic implications, mitochondrial dysfunction implications. Yes. It also has all these beautiful ACE receptors that are all over the surface. So any of our endothelial cells and our tissue, our organs are covered with these ACE receptors, which are they're like signaling agents. And so especially in the hormonal milieu, so they're very sensitive to that. So I'm looking at things like metabolic health, epigenetics, hormonal health. All of these things are no different than how I look at a patient with cancer. And so it's really interesting. My first instinct when I work with somebody who's got a kidney, because I had a private practice for 17 years before I started focusing entirely on cancer, I'm looking at autoimmunity primarily first, even with PKD, even if there's a genetic component. Because there's a lot of people walking around with PKD that may never even manifest symptoms of it, may die with it and not even know they have it, because it can show up later in life. It doesn't just born and see it. And so like, what was the mechanism? What was the switch that turned it on? And so we evaluate that. Yeah. And then if you want me to get a little woo-woo and esoteric, I also trained in Chinese medicine. And in Chinese medicine, the kidney is the ruler of our essence, our energy, our vitality. Yeah. And so it gets hit. That's also our mitochondria, right? In Western, how it translates there. So the mitochondria of the kidney are also very vulnerable to damage. Oh, yeah. And then this other piece that's a little bit more esoteric and woo-woo is kidney is all about fear and anxiety. Yeah. And so I often, people with kidney dysfunction, whether it's PKD, whether it's kidney cancer, whether it's nephrosis or nephritis, any of those patterns, I'm usually asking them about, what are you afraid of? Or what are you anxious about? And so we go there as well. As well as the physiology and the genetics, we go into the emotional as well.
So you actually, this wasn't part of the talk, but
Yeah.
you actually have some experience with polycystic kidney disease patients?
Very much. I had like I said, I had a private practice where I saw basically all the specialists in my town, a very small town in Colorado. When they failed our patients, the patients would come and find somebody like me. When standard of care had run all the things they could do, they would come to somebody like me. So they'd come for Chinese. At that time, I was doing a lot of Chinese medicine, acupuncture, and Chinese herbs. I'd also studied Ayurveda for a long time, so I'd apply some of those approaches. I am a naturopathic doctor, and applied those approaches. But I also worked in conventional environments. I worked in a pain hospital. I worked with a neurologist. So I worked in standard of care environments, and we worked together, not separate of. I was never seen as inferior. They would say to me, if I can't help them, I know you can.
Right.
And so it was great that they also appreciated, and they would help the patient dig deep into why they had those symptoms. But PKD was something I saw entire families of this. And so I'm speaking to your community that already knows this, but we would learn early on, if there was a mother or father and they have children, we could start those kids on understanding how to take care of their kidneys from the get-go, how to test and assess and address their own terrain to know what triggers might you have on board that are making this disease manifest or express.
So you're saying there's families that have members with progressive age that are not exhibiting like any cystic symptoms?
I've had a few of those that were, not back in the olden days, but in the last few years with the onset of early diagnostic imaging techniques like Prenuvo, Ezra, some of these non-toxic, non-radiation and non-contrast dye imaging to take a look inside of people's bodies for overall health assessments.
What is that exactly? I haven't heard about that.
So it's a specialized MRI device. Prenuvo is actually getting ready to open up their first one here in the UK. Right. But they're all over the United States now and expanding. But it's Dr. Argabala is a radiation oncologist and I believe a chemical engineer out of Vancouver, Canada, out of BC, who got tired of poisoning his patients with gadolinium and contrast dye and got tired of all the radiation for CT scans to do the imaging and even radiation treatment, right? That was his job. And he knew he could repurpose MRIs to do a better job, to be more sensitive and specific like a PET scan, but without all the radiation, and to be more visual, bringing the visuals to light without contrast dye. And he went to work and developed basically a better MRI device without either contrast dye or any radiation. Amazing. And there's two other companies on the market. Ezra is one other, and I don't remember the third, but Prenuvo is the king of the industry right now. And these are, you can walk in off the street and go have this done. You don't need a doctor's prescription.
So
and
no injections?
No injections. I just had mine done in April.
And can they show metabolic activity?
Metabolic activity, as far as some things that you can see the fatty, depositions internally around the organ. So that's really powerful. You can see function and flow of like the ureters. You can see that's where I started seeing PKD across, like, unbelievable. We started like popping out of like these like kidneys that were like 3 times the size and covered with cysts and completely asymptomatic. Their creatinine levels are totally normal. Their cystatin C levels normal. No issues on their LDH, no symptoms, maybe like a little lower back issue, or maybe a little bit of got some urination issues, but nothing that made him think it was just life. Yeah. Beyond just life. And so there were some accidental finds. So getting curious as well, what are they doing differently? And because of the population I serve, most people get very metabolically flexible. Yeah. We work with getting their insulin down, getting their inflammation down, getting their hydration up, getting their organs of elimination functioning well. The fundamentals. Right. So I think they probably accidentally were treating this without even knowing it. But my patients that actively knew they had these issues, historically they were put on things like certain biologics or steroids or other medications over time if the disease was progressing. We were able to use a lot with Chinese medicine, a lot of Chinese herbs and acupuncture. That was my favorite tools when I was in private practice for PKD.
So what were sort of the outcomes that we were looking for? If you compare
improved kidney function,
a family like that.
Yeah, improved kidney function, improved overall quality of life, so symptom support, and just helping people understand, like, take care of your kidneys, man. Don't trash them. Don't you're not someone who has the luxury of getting easily dehydrated.
Sure.
You know, you need to take precautions when you start to see inflammatory markers going up. If you have your blood pressure starting to change, you've got to be heading that off, because diabetes and hypertension kill your kidneys. And then the treatments we give you for those kill your kidneys.
Right.
And so it's this crazy dance we get into in standard of care. When you start to get in the standard of care loop for this type of treatment, you will inevitably progress it.
Sure.
Yeah.
Yeah.
I mean, I'm preaching to the choir here. It feels kind of silly to have this conversation with your team, who probably could school me more than anybody else in this industry, because you're living it. And the patients are who have the feedback much more than their doctor's experiences.
Yeah.
Yeah.
Yeah. So in your talk, you mentioned something about selenium and about supplementing selenium, and specifically about selenomethionine. So
Yep.
what is the significance for selenomethionine in cancer and possibly in PKD?
Oh boy, this is a whole biochemistry, and I'm not going to do that because the brain cells are dead after days. But in healthy cellular metabolism, there's think of a clock moving in the right direction, the clock direction that you want it to go. And that's part of this pathway of homocysteine, methionine, moving in the direction that everything spills forward.
Yeah.
When we make a metabolic shift in cancer, that pathway goes backwards. So whereas methionine is helpful to lower homocysteine, to balance out the homocysteine levels in the body, which is a marker of inflammation and endothelial dysfunction, which is important in the kidney world as well. When the metabolic shift happens in the cancer world, this goes backwards, and methionine builds up homocysteine accumulation in the body, which is a known driver of angiogenesis, further inflammation, and more endothelial damage, reactive oxygen species. And so you want to be careful to drive the methionine pathway. Now, not everybody it's very rare actually, but you got to test for homocysteine.
Yeah.
So in our patients dealing with cancer, we test them for homocysteine routinely. And then if it is elevated above 7 in my standards, above 10 in some other doctor's standards, the range they say is fine up to 15. You're screwed if you're up to 15. Even if you're not cancering, that's not a good thing. And at that point, we then do what we call a homocysteine challenge, and we put them on very specific methyl donors, B1, B12, folate, sometimes TMG for a week, 10 days, retest the homocysteine. If it drops into a normal level or drops significantly, we know that this is just a methylation issue, and we can just help this person just stay on methyl donors. If it stays the same or gets worse, we know methionine is driving this cancer process.
Really?
Yeah.
And is there also a connection to vitamin B2 with the homocysteine in that case?
Yeah, absolutely. Especially if they've got MTR, MTRR.
Yeah, because that's the standard biohacking thing,
Exactly.
Go straight to B2. But
and B2 is kind of that. But B2 is kind of a good B vitamins for dummies, because riboflavin can be incredibly, incredibly helpful for so many conditions, and it doesn't tend to cause problems. Like folate can cause problems in people.
Right.
Certain forms of B12 can cause problems in people. B6 and active cancering is not a good thing, right? Because it will also drive up the homocysteine levels. And so these are the things where it's kind of nice when you're like, well, B2 is kind of play it safe B vitamin and can at least be a little bit of support there.
Yeah.
Yeah. And there's so much because it's also impacting those ACE receptors. And
really?
So, yeah. And I'm assuming your community, when we think ACE receptors, we think everything that's lining all the endothelial vasculature, but also all the endothelial linings of all of our organs. And the ones that are most sensitive and most dense in those receptors are the kidneys and the gonads and the heart.
Right.
And these are also the things when we had this lovely pandemic that we went through, that is what the spike protein was targeting, was our ACE receptors.
Yeah.
Right?
Yeah.
And then ironically, the treatment for that was targeting the ACE receptors. And so that's why you've seen such an influx.
Smokers didn't get sick, right?
Exactly. You nailed it, because those ACE receptors are making it vulnerable. So the lining of the lungs, the lining of the intestine, the lining of the gonads, the lining of the kidneys, the lining of the heart. So, and all that leads to, when you have issues with spike protein going into those ACE receptors, you create these little microclots.
Yeah.
And we know that's a bad idea for kidney function. We know it's a bad idea for endothelial function, heart function. And so those are the patterns we start to look for long before someone's gotten sick with COVID or had an injection that's affecting that same receptor site, that can make some people more vulnerable to having side effects with that.
Yeah.
And so it's not even about, this isn't a controversial discussion, it's just the basics of the receptors.
Makes sense.
Right? And so there's so much we can do, like molecular hydrogen, very helpful in dealing with the spike protein issues.
Yeah.
Hyperbaric oxygen, some of these other things that are going to break, like fibrinolytics. So think proteolytic enzymes. These are the things that break up those microclots and start to soothe the inflammation of the endothelial lining. So by default, all of our tissues improve. And our kidneys are, man, it's like we need to really coddle those babies.
Yeah.
We really underestimate. A lot of people talk about the liver, and it's so important to deal with the liver. The liver is kind of its own self-organizing. It knows what to do. The kidneys are, they need a little help.
The liver can regrow, kidney not so much.
Not so much. It takes
those
a little
nephrons,
bit. Yeah.
I'm still waiting for the day where they announce that they found that they were regrowing nephrons all along. So, because
I got goosies.
They were saying neurons can't be regrown,
and
right?
here we know
and now
they
we're
are.
doing it every day. So,
well, given how many patients I've worked with PKD, nephrosis, nephritis, with lupus that has affected the kidney, other autoimmune diseases that have completely destroyed the kidney cancer, I would say they are absolutely able to regrow.
Yeah.
And those are the things that I see clinically, both on imaging and lab testing.
I was sort of trying to tease this out earlier, a couple of weeks ago, or a couple months ago. And I was trying to distinguish between what is nephron regrowth and what is just like glomeruli.
Good. Yeah.
growth,
And there's probably a little differentiation to be had there.
Yeah.
Yeah. Really good. Yeah.
Because those officially they can enhance and
because we can improve our filtration apparatus, but I do think, especially people who've come to me with late stage of these conditions, who've been through the biologics or lots and lots of steroids or other things, and they just kind of kick the snot out of everything, and there's really no nephrons functioning anymore. Like that's what it gets down to. We've seen even there, it's like seeing people with insulin dependent type 1 diabetes, which is typically insulin dependent anyway because of the loss of the beta cells. There's actually a few compelling studies even that you can repair and regrow some of those.
Yeah.
And so this is what I love. And I love that your colleague, your friend, Dr. Wimes just talked about this at this conference about there's a lot we don't know because no one's really studied it well.
Yeah.
And there's ways to know. When we think about the impact of ketone bodies on the improvement of overall mitochondrial health and function, the lowering of interleukin-6, the lowering of the change in perfusion, micro circulation that ketone bodies bring, the signaling agents that it brings to changing out hormonal discussions, the impact it has. What does ketone bodies do in the body? They dump things like sodium and potassium and magnesium, all run through the kidney. How would they not impact the kidney? And that's why we're seeing this beautiful improvement.
What do you think about if people are on keto for longer periods, they see a drop in ketones on their blood test?
What we're finding with that, and actually I just came from a conference on this, is that as your body mass normalizes, basically you'll have higher ketone levels when you have a little bit more body mass, body fat content. And then it'll come to the point where it's not showing that you are any less responsive to ketones. What happens today in the way we test for ketones is we are only really looking at ketoacidosis on our ketone monitoring. That's just the nature of the beast that we've done forever. So when we do blood ketones, when we're looking at BHB blood, we're looking at why these were divided, or why these devices came to be was to screen for ketoacidosis.
Yeah.
So then we've repurposed them and applied them into the fitness era and the metabolic oncology and metabolic psychiatry and metabolic nephrology and metabolic cardiology.
Right. Same devices.
Exactly. And so I get this screwed up a little bit. So apologies to your listeners if I transpose them. But one of them we're looking at ketogenesis and the other one we're looking at ketolysis. You reach a point we don't have the means to test. I'm pretty sure ketogenesis is what we're seeing when we do the BHB testing. We need to see ketolysis. Okay, maybe you should not see, just like you shouldn't see ketone bodies in the urine after a while when you become keto adapted, fat adapted. The same holds true when you start to become more adapted in the serum. And now it's did those ketone bodies go into a receptor site and have an impact, or are they still in circulation? And so that's where things start to change. We don't have the testing yet. That's actually what our lab is doing in Arizona, is differentiating between this to see. We're just asking the questions. We don't have the answers yet, but we're asking the questions because we think there's different mechanisms happening at different stages of your own metabolic journey.
So I guess that falls under the umbrella term of like ketone flux. Is that thing?
Absolutely.
Because there's very little information about this online.
Yeah.
And, your experience from practice is a little more interesting.
Well, and I think people like Isabella Cooper, Dr. Isabella Cooper, who's out of England. I mean, she's, this group, she's done she's asking some of these questions. She's starting to explore the flux because her studies have been in healthy women in long-term ketosis. And we can learn a lot because most of the time when we're studying ketosis, we're studying like and they're healthy women that are not athletes and that are not on hormones of any kind.
Yeah.
And so most of our studies have been on like uber athletes in like the biohacking world, or patients with cancer, or patients with some severe metabolic dysfunction.
Right.
So we're learning just as much from the healthy population of that keto flux as we are from the disturbed metabolic function. So there's finally studies being done. I think the next 10 years is going to be incredible what we learn. And that you and I will be sitting here 10 years from now saying, well, look, you can build an entire new kidney.
Yeah.
In this window of time with all these new tools that we have.
Won't even need ketones for that.
Right. It's just like crazy. So
that's going to do in the lab. Yeah, maybe stem cells as well, right?
Very interesting.
There could well be a place for stem cells in the future.
Absolutely.
Kidney as well, right?
Absolutely. Yeah. Very cool.
Of course, in PKD, you don't want to have it grow too much.
Exactly.
Grow
it's
the wrong stuff. But
So
stem cells are a bit intelligent as well, right?
One of my favorites, I can't believe I didn't mention this, probably the most powerful therapy beyond ketone bodies I've seen for PKD in any kidney dysfunction is low-dose naltrexone.
Really?
So that's a whole nother talk. We don't have the bandwidth tonight, but you just mentioned, what made me think of it is the modulating effect on the immune system. You don't want to stimulate and you don't want to suppress. And PKD, like, it's crazy because the way we treat, it's like all on or all off with the switch. And LDN is about this. The person you might want to have a conversation with is Dr. Angus Dalgleish, who is out of the UK. He is a famous immunologist, oncologist, a cancer vaccine design dude, but he's who found discoverer of the CD4.
Okay.
And the discoverer of toll-like receptors, which play a key role in this as well. And so he and I have spoken over the years at low-dose naltrexone conferences, and he's talked about its utility in so many of these types of conditions.
Yeah.
And
I
it's
played
so
around
cheap
with it
and safe
a little
and simple.
Bit, but I didn't know that there was a kidney-specific aspect to it. I know the thyroid aspects for
there's a lot
autoimmunity and stuff like that.
Yeah.
But I mean, in the PKD world, I guess there's a lot to be discovered.
There is a lot to be discovered, and there's a lot of people thinking that it is more autoimmune than genetic. I mean, it's like the genetic predisposition, but an autoimmune component of what sets it off.
Do you have a more detailed thought on?
God, it's been a long time, my friend. That's more general, I think. It's been a long time since I played in that world.
Yeah.
Give me cancer anytime.
Yeah.
Okay, well, that kind of,
I know. We don't want to be too.
I know, right? Thank you. But I want people. It's you're creating curiosity. Maybe other people listening will go and dig deep and find the answers and maybe more questions.
Yeah.
Cool.
Yeah. So I mean, if somebody who's watching this and they're getting diagnosed with PKD or even with cancer, what would be your starting point for them to start looking into this, because there's so many conflicting therapies out there?
Yeah. Don't start on a therapy. Don't. You got to do some research first. You got to do an inquiry inside. You got to look at everything you're putting in, on, and around you. You got to look at labs. You got to look at genetics. You got to take a deep dive. You got to know what you're dealing with. That's the concept of test. And then you assess, what are the patterns that you're expressing? How does your PKD look different than this person's PKD? Right? What is unique to your process that's all you? And then you address. That's when you start to devise a rational treatment plan that's based on this is the information we have, and these are the rational approaches to treat it. And then you retest. And it's an iterative process. Are you on the right path or are you not? Yeah. And so what people tend to do is they tend to look for the fix. They rush right to the endpoint, to address, to protocol, to spending the money on shit tons of supplements and products and diets and lifestyles and all the things. Don't. Start simply. Test up front to know what you're dealing with and then address it accordingly.
And if you say test, I mean, people don't have many people that think, okay, I go to the doctor, I order the blood panel, and then I'm done. So that's not what you're saying.
No. And so, I just did a presentation. I kind of put up my standard, what I call my onboarding labs. If anybody's interested, they can email me at Nasha at MTIH, Metabolic Terrain Institute of Health, mtih.org. I'm happy to send them kind of my list of what onboarding labs I would be looking at in general, which is good, cancer or not, PKD or not, that we should all be looking under the hood.
Just to balance things out before you even start about treating anything.
Exactly. And then and then you've got a bit more of a precise, personalized path forward.
Yeah.
That's a lot of P's.
Yeah.
With the PKD.
Yeah. And one last question.
Okay.
I was very surprised that you were saying there were families with pretty old people that had the gene. So did you ever confirm that? Or is it more a supposition?
So it's been I'm trying to think the last time I had a PKD like in my practice and think it was probably around 2014. So it's been a decade.
Yeah.
I'm pretty sure I did not know half the things I know today or any of us would have known today 10 years ago. I'm imagining you know that. Like it's probably so different in the field. And so what we just started seeing were patterns. So when I would take care of a family member, because I started doing epigenetics with my patients in like 2008 or 9. So I started running single nucleotide polymorphisms on entire families.
Like 23andMe type stuff.
Exactly. And then it was just 23andMe. Now I use other companies. There's actually a few here even. And then I started seeing these patterns. And then because I run labs, every one of my patients, young and old, ran annual labs. So I saw that. Then I would run functional testing if there were other weird symptoms that weren't responding to the most fundamentals. So if I kept seeing like chronically low white blood cells, for instance, and they shouldn't have that at all, I'm like, okay, is this stress? Is this heavy metals?
Wow.
Is this a co-infection? Those are the 3 main drivers of why you'd have chronic low white blood cells.
Yeah, and all of those can wreak havoc on the kidney.
Thank you. Exactly.
Yeah.
And then suddenly where I lived in an old mining town in Colorado. Every one of my town had kidney issues because arsenic, mercury, uranium, radon, everywhere. And what has to filter out most of that? Yeah. So we had to work on the terrain. If I went and just treated your kidney, but you're still living in the toxic soup, you're actually going to be at worse. So one of the biggest things I've always pushed patients away from is, let's say you find out you have all these metals. The last thing a patient with kidney issues of any kind need to do is chelate.
Right.
You will kill the patient. I'm one of those people that have almost gone into kidney failure twice.
What's the mechanism there?
I think it just overwhelms the whole system. It's like you're like pushing against something. It's like, I can't cycle this through enough. My teachers in the environmental medicine space would probably give you much more thoughtful, specific, physiologic, biochemical explanations. But simply put, too much input with no ability to get it out.
So detoxing the chelation agent, bound or not,
It's
might be
so intense.
injuring.
And they're large. And so they just kind of, it's like grating, it's like a cheese grater in the that
large
patient.
complexes that might sort of
Bog it up. Yeah. And so that's a big one. The other big one people always get surprised about is everyone like who gets diagnosed with some chronic illness or cancer, they all become juicing whores.
Yeah. Oxalates.
Thank you. Which is such the unspoken demon of kidney function. The worst
idea.
And it concentrates all the chemicals.
Yeah.
Like glyphosate.
Right.
Also just destroys the lining of all of our organs and gut and tissues.
Yeah.
So if you don't identify the problem and remove it, and you just go in and treat the symptom, you understand this could actually get a lot worse than better. Yeah.
Do you think there could be a gut flora that leads to PKD not erupting?
I actually very much do. I think this is also a very exciting field. And there's a company that I just got keen on. I'm vetting them, so I'm not endorsing, I'm vetting. They're called Vitract, Vitract. They just came on market on January 2024. They're doing some very interesting kind of fingerprints of the microbiomes, and we're starting to just play with this across the board in a lot of different patient types and a lot of processes, because that's what we're learning. And even in the cancer world today, we're like, the tumor itself has its own microbiome. And the microbiome, very different than even the microbiome that tumor is floating around in.
Really?
I know.
Just like the cyst.
Exactly. They call it, like they even talk about the mammary gland microbiome is unique to the digestive microbiome, is unique to the vaginal microbiome, is unique to the brain microbiome. Like, This is what's so cool to me. And then we're able to come down. This is where I love the era of personalized medicine. Like, wouldn't it be just really cool to say, oh, this is your today, and these tests are getting cheaper and cheaper, so we can do iterative testing.
Yeah.
Because you can change your microbiome in just a couple of days. And so it's like, did I move it in the right direction? Did I do anything? Or is it going in the wrong direction?
Right.
And it becomes inexpensive when you do these serial testings to know, wow, what was I missing? And suddenly you watch these profiles normalize to a perfect condition in the ecosystem of the body.
At least according to whatever test we have, right?
Exactly. And
so
again,
difficult to know what.
in 10 more years, there will be 100 of these companies on the market. Because there's a few already, and like I used Ubiome in the day and Biome. And
exactly.
And my problem with those is because I know our biomes change so quickly, but I want that in the moment data that's inexpensive, that I can see if what I'm doing is making a difference.
That would be great.
And the patients tell you immediately, they feel it differently. If you nail their microbiome cocktail,
what they need.
I mean, it's not like weeks, it's hours to days that they know something is different. It's pretty cool. Yeah. I should get you connected with some of these people that I'm learning a lot from, because it's a field in its infancy.
Yeah.
So I'm excited to see where that will go.
Yeah, it's amazing like how much is still in its infancy after so many years of medicine, but it also feels like some of it's being suppressed from some of the angles.
Yeah,
it's our duty to get this out to people.
Yes, thank you. And thank you for doing that. I mean, thank you, because this is another community of disenfranchised patients, the PKD world.
Yeah.
And it's, you gotta create the curiosity and keep digging.
Yeah.
Yeah, don't give up. There's no if you don't figure it out now, it doesn't mean it doesn't exist. It doesn't mean there's not an opportunity of recovery or stability or maintenance.
It goes for any genetically 100%. Determined disease, right?
I love that.
Nothing is really determined, right?
Exactly.
You can always...
Even standard care says 95% of what we have going on is determined by our choices. Yeah. And then people go, oh, you're blaming the patient. No, I'm empowering the patient. You don't know what you don't know until you know.
Do something about it.
Exactly.
Yeah, amazing.
Thank you.
Thank you so much.
Lovely. Thank you. Thank you, everybody. Thanks.
All right, everybody. Have a great day, and thanks for watching. If you like this video, I hope that you will subscribe to this channel, share it with your friends, and comment below which other topics you would like to see discussed next on this podcast, because after all, I'm doing this for you. Until then, happy healing.